Hi, I'm Lawrence Bergstrom, registered osteopath and non-surgical spinal disc decompression specialist. In this video, I'm going to talk to you a little bit about non-surgical spinal decompression, why we have it in the clinic, and how it can help you. Non-surgical decompression therapy, or IDD therapy as it's known, was developed in the US over 20 years ago by neurologists and orthopedic consultants. And they developed a system to treat the spine non-invasively. So that means no surgery and no injections. Now, one of the reasons they developed this was because there are cases where surgery has failed. Manual therapy, that is to say the physical therapies have failed, medication isn't resolving the patient's pain, and injections haven't helped either. And it means that the patient could still be in a very activity and life-limiting situation. So over 20 years ago, some medical minds got together and they came up with this, the non-surgical spinal decompression table, or the AccuSpiner table. Now, a lot of our patients joke, and I thought I'd share this in this video because a lot of patients come to us and say, can you put me on the rack? Or they'll actually say, I feel like I need to go on a rack. I feel like I just need to be stretched. And in part, that's what we're doing with this, but you'll be pleased to hear it's a lot more scientific than that. This system was developed for people that are in severe pain. So if you have a bit of backache or neck ache, you don't require non-surgical spinal decompression therapy. That can normally be managed very, very well through hands-on treatments such as massage, osteopathy, chiropractic treatment, physical therapy, exercises, maybe strength and conditioning, that kind of thing. So when people are coming to us, if we're contemplating using this type of treatment, they're in a lot of pain. And normally they've tried everything else. They've been through all the physical therapies, they're maybe on a list for surgery or injections. Either they haven't worked or patients don't want to go that route because of course it becomes progressively more invasive. So this system of care, and it is that, it's a system of care. This is a very valuable tool. It's an extremely useful tool in our system of care, but it's not the only thing. We still utilise manual therapies, hands-on treatment, so that's osteopathy, massage, joint manipulation, mobilisation, acupuncture, and of course exercise rehabilitation, because this is a very, very useful tool. But a little bit more on, how does this actually work? Now, if I just give you a little close-up of the model of the spine here. So what we're looking at is two vertebrae and a disc in between, and a section of spinal cord and peripheral nerves. Now, if I turn it this way, at the back you can see what we have here are what are called facet joints. And when the spine is the correct way up, what happens is they open and close on each other. They side bend on each other a little bit and they rotate on each other a little bit. And on the inside here, or in between, if you like, the jam in the donut, is the spinal disc. Now, as the disc degenerates, as it becomes progressively more thin, it puts more pressure on the facet joints at the back here. Now, as manual therapists, that is to say, using our hands to treat the spine, we've got a few techniques that we can use to open and close these facet joints, do what's called gap the facet joints as well, which can help with the side bending and the rotation a little bit and take a little bit of pressure off here. However, if this disc is sufficiently degenerate and thin, any of these manual techniques at best are going to give short-term relief. And the more severe this becomes, the more potential there is either for compression towards the spinal cord, which in rare cases can be very serious and severe, or more commonly, it's going to start to compress the nerves here. And once those nerves are sufficiently compressed, once you go to your doctor, so that is to say, if you go to your GP, the GP is going to take you through the manual therapy route first. If that doesn't work, then it's medication. If that doesn't work, then you're referred to orthopedics. And then the orthopedic consultant's only got 2 or 3 choices. They can inject, manage you, watch and wait with physical therapies and medication, or they're going to try a procedure of some sort where they're going to do perhaps a laminectomy where they remove a bit of bone, a foraminotomy where they go into this window called a foramina and try and clean that up, a microdiscectomy where they start to cut away a bit of disc, amongst other procedures. So some of those can be very successful, and unfortunately in about 74% of cases surgery fails long term, so it can get you out of a hole short term. There are a percentage of more straightforward procedures which can have a long range positive outcome, but then unfortunately about 74% of spinal procedures surgically don't resolve problems in the long run and can require what's called a revision. So within 5 to 10 years you may well find that you need further surgical intervention. So how does this work? Well, we were talking about, as manual therapists, osteopaths for example, we can mobilise the spine a little bit. So if your changes are not too severe, that will be enough. A bit of manipulation, some exercise and some lifestyle advice, and you'll go on to do very well. But this big imposing piece of kit, or the rack, comes in at the point where this is not going to be resolved by our hands. So it's a process. Now, one of the things we make very clear to all our patients is it's a process of care, and that starts with diagnosis. So number one, we need a clear diagnosis. And how do we arrive at that? Firstly, about 80% of the case history gives us the diagnosis. So that's your story of pain. So we listen very, very closely to that. And myself and all my team have suffered with severe spinal injuries and problems ourselves. So not only do we have the necessary medical training and clinical training, we understand it personally. So as a consequence, our ears are finely attuned to the language that you use specifically related to your problem. So number one, there's the history. And then number two, a thorough physical examination. So we look at your movement, we look at your movement patterns, we get you to point to exactly where you feel the pain. And then we will carry out an orthopedic examination, which is a range of different tests. We'll carry out an osteopathic examination, which will look at detailed movement and your movement patterns and restrictions and your pain points. And then we carry out a neurological examination as well, where we're looking at muscle strength, we're looking at nerve function and so on, areas of sensation, altered sensation. We bring all of that together. Now, there's another thing that's extremely important with all of this. So we haven't finished our job at that point. We now have what we would call a working diagnosis, but we want to prove to ourselves that we're correct in that. So the next thing is an MRI scan of your spine. Now, some patients come to us, they've already had an MRI. If it's within the last, say, 12 to 14 months, we're happy. Medical imaging has a shelf life of about 12 months. So if somebody comes in and they say, it's okay, I've got an MRI, it's 4 years old, we'll take it as background information, but nothing more, because we will want an up-to-date MRI. We can refer you for that. And in another video, I'll talk about MRI, its value, and why we refer for MRI. But the key thing is really to safety net you against one of a small number of problems in the spine or contraindications that would render this off the table. And then secondly, we want to narrow to that diagnosis, because you might have multiple levels of change in your spine. To be honest, by the time you get past 35, without wishing to shock everybody out there, you will have multiple levels of change in your spine. It just depends how severe. So then what we need to do is target the specific area that's causing you your pain. And then that's where it becomes a process of care, a process of treatment. So what we don't want, we get phone calls every week from people saying, hi, I see you do IDD therapy. Can you book me in this afternoon? I'd like a session. The answer is no, sorry. What we can do is we can book you in for a consultation to then find out, do you even need this therapy? Because you might not. There are a lot of people that ring us up and we actually say, you don't need it. We can manage this another way. But the people that really do need it generally are in agony, either severe neck pain severe low back pain and or radiating pain down an arm or a leg. It's not getting better. So then that becomes, as you can already tell from what I've described to you so far, we're already quite an involved process. But why is this important? Because we want to be the one-stop shop now. You may have been to other places. A lot of patients we see have already spent a lot of money, maybe thousands of pounds, to reach a point where they're no better, or at best they had temporary relief. So we're very honest and we say to our patients, yes, if you've come to see us privately, it is going to cost more money, but when you look at the amount of money that you've spent already and you don't yet have a resolution to your problem, we want to be that one-stop shop, if you like, the last place you come to where you get a clear diagnosis, you get an action plan, a management plan, and then we move you forwards to a much better state of health where you go on to feel much stronger, much healthier, moving better, pain's greatly reduced. Now, when we do all of that and we get all of those, what we call medical ducks in a row, we have a 92% probability of greatly improving or resolving your pain. So that's significant, but we can't shortcut it. So we never, ever, ever put somebody on the technology and just give them a stretch. Okay, that's not how it works. Also, this isn't traction. A lot of people will say to us, yeah, there's just traction. It isn't. Good old-fashioned traction, as it was in the 70s and the 80s, helped probably about 40% of people. Now, if you've just got a stiff back, degenerate discs, facet joint arthritis, and you give it a good stretch, the likelihood it will help you. But when people come to us for this level of care, old-fashioned traction, it died out really because it was non-specific. Also, the diagnostic knowledge wasn't there, so it injured a lot of people or certainly made their symptoms worse or, didn't help them. Now, on that note, before I talk a bit more about how this differs from traction, people will ask and they'll say, well, can this make my back worse or my neck worse? The answer is yes, it could if we hadn't done the necessary medical workup beforehand. You will very likely at some point experience an increase in soreness in your symptoms as we treat the tissues, but it's a little bit like doing a lot of gardening. You're going to feel sore after that. Or if you have a workout in the gym and you're not just there going through the motions, but you're putting some effort into your workout, you're going to feel some soreness after that as the tissues do what we call adapt. So your tissues will definitely be adapting when we treat you. Now, going back to my description about what can happen here, with our hands we can do a little bit of manipulation and a bit of mobilization. If your symptoms are not too severe, that's great, that'll help, they'll do you a lot of good. However, once your symptoms are severe enough, that's not going to work. Now, what we can't do with our hands, and if I give you a demonstration here, so we'll assume the disc is really compressed at this point. What we can't do with our hands is we can't physically start to pull it apart, okay? Now, when I say pull it apart, we're not talking about pulling the tissues to pieces, we're talking about decompressing it, deloading it. If you imagine, so your spine is here, you've got top-down compression, we can't lift the pressure off with our hands. There's nothing that we can contact with our hands, and you could be really big and powerful, but there's nothing that you can grip, and it's non-specific. You can't hold that person for long enough to start to decompress that disc. Now, the reason it's a process is every time you're on the table, what happens? If you think of the musical instrument, an accordion, what it does is it uses air and it expands and it contracts. Okay, so what we're doing with this disc is it's expanding and it's contracting, and then it's doing what's called oscillating. Now, this is the only system, the acuspinal system is the only system that has this oscillatory factor. Now, what that means is at the highest tension, the highest pulling force, when you're lying on the table, it then oscillates. So effectively what it's doing is pumping that disc. Now, why is that important? that disc has become degenerate. It's not getting blood flow, it's not getting oxygen, it's not getting water in there. So it's becoming more and more and more degenerate. That then causes an inflammatory soup, if you like, in the disc, which is then starting to irritate nerve endings, leading to pain. So we want to get more blood flow into that disc, because unfortunately spinal discs, our ligaments and our tendons, they have a sparse blood supply. They have a slow blood supply. So we want everything we can to boost that. So it's a course of treatment. Now, typically, patients will come to see us from anything from 18 sessions up to 40 sessions for one disc injury. Now, if you've got 2 or 3 discs, we're talking multiple levels. When you treat one level, the other levels benefit moderately, but this is so specific, and we'll provide you with another video at a later date where we'll actually go through the setup, where you'll get to see a patient going onto the table, being comfortably placed on the table, and then we can talk about how specific it is through the computer targeted program that we use for each individual patient, because the majority of people come to us with similar levels. If it's in the lumbar spine, it'll typically be L4, L5 or L5S1, so the lower lumbar disc levels. But there are occasions when it could be as high as L1, L2. And in the neck, again, it tends to be the lower discs. So we're talking C4, C5, C5, C6, C6, C7. So the lower neck that we'll tend to treat, okay? So yeah, we have a lot of fun with our patients, because they'll come in, they'll say, it's time for the rack. Now the good news is, unlike the medieval rack, which was a method of torture, this is nothing like that. It's comfortable. People often ask, will it hurt? The answer is no, the treatment should never hurt. You might feel some soreness afterwards, and we warn our patients of that, or we advise them, and we always advise to ice the area afterwards, because it retards and reduces some of the soreness. But it's very rare that we see patients that say, oh, I'm just so sore, I'm so sore, it's so painful. And we also have protocols in place for that. So if somebody is exceptionally sore, we don't just say, okay, well, that's it, we stop the treatment. We can reduce the high tension. There are numerous things that we can do. So it should be a very comfortable process. I go on here for maintenance. I've had severe spinal injuries in the past through elite level sports and accidents and various things. So I find it very useful on a maintenance level, and a lot of our patients, once they've gone through that journey of being largely almost completely disabled, or at times temporarily disabled for weeks or months, and they're back moving well again, part of the advocacy from the North American Medical Group, which are the if you like, the think tank that developed and continue to develop non-surgical spinal decompression treatment. They advocate a reducing period of maintenance care following an intensive course of treatment. We're so pleased with the results that we're getting for our patients, which previously, I can say hand on heart, I would have had to refer all of those to orthopedics. They would have been out of my hands, and I would have had to refer them to orthopedic consultants. Now, very rarely do we. There are occasions we still need to refer, and they're very important cases when we need to, and that's what orthopedic consultants are there for, once everything else non-surgically has been tried and failed. But that happens rarely. We're so pleased with the system and the knowledge that we're gaining every day, every week, patient by patient. And we've been providing non-surgical spinal decompression now for a good 5 years. We're so pleased with the outcomes and the results long term that we've invested in a further one of these. So soon we're going to have a greater level of expansion within the clinic, which allows us to provide you a greater level of care. So I hope this has been interesting to you, because people are starting to become more aware of non-surgical decompression. Up and down the country, we're starting to see more clinics adopting this particular system of care. We have over 25 years experience of treating severe spinal pain, and we've been providing this particular therapy within that program of care for the past 5 years with excellent results. As I say, in 92% of cases, we can sit with our patients and they can confidently say, I'm either greatly improved or I'm resolved. So it's a fabulous tool to use in our armory of getting you back to fitness and health. So I hope you've enjoyed the video, and there'll be another one coming where we'll go through the process of how we set a patient up, exactly what we're doing, and you'll be able to see how comfortable it is. But thank you for watching.